So let's look at individual poisons. I'll first talk about paracetamol poisoning. It's the most commonly ingested medicinal poison in our children. It can be poisoning can be due to acute single exposure or ingestion following repeated supratherapeutic ingestion. For example, a parent giving a higher dose of paracetamol over a couple of days. And you need to consider the drug formulation, the dose, the time since ingestion, and if available, a paracetamol concentration, and the clinical and lab features of acute liver injury when you assess a child with paracetamol poisoning. And in general, a toxic dose, a single ingestion of a toxic dose of more than 200 milligram per kilo is potentially toxic and is an indication to start treatment with a standard regime of N-acetylcysteine. So we don't have this paracetamol levels in our country, except in like a few stations like National Hospital, but it is also not consistently available in National Hospital. So where the paracetamol levels are available, you can use this paracetamol nomogram reliably to select patients needing treatment as well as to guide ongoing treatment. So here the red line indicates the treatment threshold, and on one side the concentration of paracetamol given in micromoles per liter, and on the other side in milligrams per liter. So this means so at 4 hours an ingestion of one criteria is if a child has taken more than 200 milligrams per kilo, then you need to administer NAC. However, if you are not sure, if the history is not clear, and if paracetamol levels are available, then you can do this level. And if your 4-hour paracetamol level is above 150 milligram per liter, then again you need to consider treating those children with N-acetylcysteine. So it's important to realize paracetamol nomogram can only be used in acute ingestion of immediate release formulations with a known time of ingestion within the first 24 hours. And then so you can administer activated charcoal in paracetamol poisoning up to 4 hours following ingestion. However, if the child presents with elixir or the syrup form, you have to administer activated charcoal within 2 hours for that to be effective. Otherwise, most of the paracetamol will get absorbed to circulation. And then your time frame for to do the paracetamol level is somewhere between 4 and 8 hours post ingestion. So conventionally, paracetamol N-acetylcysteine was administered as a 3-bag regime. So you administer 150 milligram per kilo over 4 hours, followed by 50 milligram per kilo 1 hour, followed by 100 milligram per kilo over 16 hours. However, the recent guidelines have changed this 3-bag regime to a 2-bag regime, which recommends NAC a dose of 200 milligram per kilo to be administered over 4 hours, followed by 100 milligram per kilo to be administered over 16 hours. If you look at the nomogram, if you have the paracetamol level, and if you can do a paracetamol level and then check in the nomogram. So we discussed that the indication for NAC is 150 milligram per liter. But if your concentration is double that, then your second bag should be 200. So literally what it means is you have to give double dose of NAC for children with massive overdoses of paracetamol poison. And then, so once it started, so you have to continue it at a stretch. So it has to be given for a 20 hours duration. So there is no like half dose, so you can't stop midway. And to decide whether you can stop at 20 hours, then 2 hours prior you have to do liver functions and if available a paracetamol level. But don't worry if you don't have a paracetamol level, you can make a decision based on ALT and INR, based on those two. So if a paracetamol level is available, if that's more than 10 milligram per liter and ALT more than 50 units per liter, then that means that you have to further continue the second bag of NEC at the same rate. And in Sri Lanka, we use methionine as well. Why we use methionine is it's quite cheaper compared to administration of N-acetylcysteine. And the Sri Lankan guidelines recommend methionine for children who present within 8 hours of potentially toxic paracetamol ingestion, which is 200 milligram per kilo. And we can use this, in situations where NEC is not available. So it's cost effective and it's reasonably safe. And also the dose-related anaphylactoid reactions and vomiting are also less compared to N-acetylcysteine. However, patients should not have any vomiting and should have no underlying history of liver disease if methionine to be administered. So let's look at how we can manage repeated supratherapeutic paracetamol ingestions. Repeated supratherapeutic ingestions include intake of more than 200 milligram per kilo over 24 hours or more than 300 milligram per kilo over 48 hours. How can we manage them? Now here we can't use the paracetamol nomogram. Here if we do a paracetamol level, they are not going to be reliable because this is like a cumulative effect of multiple supratherapeutic overdoses. So what we can do is, if a paracetamol level is available, you do it, or else you do liver functions, ALT. And if the paracetamol level is less than 20 or if your ALT less than 50, then it's unlikely to be a toxic. It's unlikely to be a toxic ingestion, and then you don't need to treat with NEC. However, if your liver functions levels ALT more than 50 or if paracetamol level available, if it's more than 20, then you have to continue NEC. And then similar to previous scenario, you have to continue NEC until your liver functions become below 50 or if paracetamol levels available until it becomes less than 10 milligram per liter. So remember, for decision making in paracetamol poisoning, as treatment endpoints, you can use INR and liver functions, as we do not have paracetamol levels. So take liver functions ALT less than 50 and INR less than 2 as therapeutic endpoints. So towards the end of your NEC infusion, if your INR is less than 2 or ALT less than 50, you can safely stop NEC infusion. However, if your ALT more than 50 or INR more than 2, what the guidelines recommend is to further continue NEC infusion, monitoring these parameters. And then let's look at oleander poisoning. So oleander, or in Sinhala known as Kaneru, is a common poison, still a common poison, commonly ingested by children and adults in the dry zone of Sri Lanka. It's not commonly seen in the Western province. So the toxin is, so they have naturally occurring cardiac-active steroids. The management of oleander poisoning is quite complicated because it's very difficult to predict the outcome. Oleander releases the toxin in an unpredictable manner, and determining dose-response relationship can be very difficult. Therefore, like we discussed, to perform a risk assessment in case of oleander, it's going to be very difficult. Therefore, what is recommended is, if a child presents with ingestion of oleander, you have to at least observe them after 72 hours because they can have delayed onset cardiac toxicity. They might appear very well within the initial 6 to 12 hours, but towards second day, they might become quite unwell. So this ECG shows a complete heart block of a child who has ingested oleander. So oleander gets absorbed to activated charcoal. Therefore, if you see a child, if you encounter a child with oleander poisoning, administer activated charcoal. And you can even administer multiple dose activated charcoal because its absorption is erratic and its absorption can be prolonged, like we discussed before. Therefore, if that's a significant poisoning, always go on to administer multiple dose activated charcoal. However, if you treat this child with bradycardia with atropine, what atropine can does is it can cause ileus, and using activated charcoal in the presence of ileus can be tricky because it can lead to bowel perforation. So you have to keep in mind this factor when administering multiple dose activated charcoal to treated children with oleander poison. And activated oleander is not amenable for extracorporeal elimination, therefore it has no place. So it's important to monitor ECG rhythm as well as cardiac parameters for up to 72 hours in all children who present with oleander poisoning. And also oleander can cause, because of this effects on the cardiac channels, it can cause hyperkalemia. So you have to look for changes of hyperkalemia in ECG at regular intervals. Serum digoxin levels are available in some countries, but it has only limited place in monitoring because there is no dose related relationship with the toxicity. Therefore, it has no good therapeutic, good use in monitoring the children with yellow oleander. So your main treatment, so treat hyperkalemia if present. So you can treat hyperkalemia with conventional treatment with salbutamol nebulizations, correct, sodium bicarbonate if in presence of metabolic acidosis. However, remember not to administer calcium gluconate because of this calcium channel blocking properties. Intracellular calcium concentration is going to be high. So if you administer IV calcium gluconate more, that can give rise to intracellular calcium toxicity, leading to the phenomenon of stone heart. Therefore, you can treat with all conventional measures the hyperkalemia except using calcium. And then atropine can be used as a bridging treatment for those with heart blocks, and you can use cardiac pacing. The definitive treatment for yellow oleander poisoning is antidigoxin FAB, which is the antidote. And let's look at kerosene oil poisoning. It's the most commonly ingested poison in children in our country. Most exposures are benign, so children are quite well, apart from having a brief difficulty in breathing. And this is poorly absorbed from the GI tract. However, you can have very severe complications in a massive overdose, such as aspiration or CNS complications, including coma or convulsions. And kerosene oil also can lead to cardiac arrhythmias in severe toxicity, such as atrial low ventricular fibrillation, and also it can lead to organ failure as well as toxicity to bone marrow and kidney. And contamination of the skin and mucous membrane leads to irritation of the skin. So management of kerosene oil is supportive and there is no antidote available. You have to remove the possible source of poisoning, and if the child is having difficulty in breathing, you can start on supplemental oxygen. And if there is significant hypoxia or significant respiratory distress or evidence of aspiration with hypoxia, child might need intubation. And if the child is having contaminated clothes, they need to be removed. Do not administer any decontamination measures as it can be detrimental, and kerosene oil can lead to aspiration and subsequent chemical pneumonitis. There is no place for routine use of corticosteroids, and they need to be decided on a case-by-case basis. Similarly, there is no place for routine prescription of antibiotics. However, it also needs to be decided on a case-by-case basis only in the presence of secondary bacterial infection. Let's look at salicylate poisoning. It's again aspirin, no methyl. So children can ingest methyl salicylate balms or aspirin tablets. It's again one of the very toxic agents. Children can be, toxicity can be due to both acute as well as chronic exposure. It can have toxicity over, multiple organs. It's cardiotoxic. It's toxic to CNS. It's toxic to lungs. It's toxic to GI tract. So multisystemic toxicity is observed. How can you manage salicylate toxicity? So, there is no antidote available for salicylate poisoning, and supportive care is the main mode of management. What you can do is, so you need to get rid of, in severe overdose, the mainstay of treatment is, enhancing elimination of this poison from circulation. So, you can use activated charcoal, even multiple dose activated charcoal if you have a doubt about salicylate forming concretions or bezoars, and you can use elimination methods like urinary alkalization to encourage salicylate to be excreted through urine. With regard to the support of breathing, children with severe toxicity might need intubation, especially those with altered level of consciousness or features of acute lung injury. However, because intubation can lead to acute acidosis, make sure that you treat with IV sodium bicarbonate bolus and pre-oxygenate with bag valve mask hyperventilation prior to intubation. So that will prevent accumulation of increased salicylate concentrations within the central nervous system. So treatment-wise, GI decontamination with activated charcoal and elimination with multiple dose activated charcoal are indicated. If the facilities are available, but in our country this facility is not available. Where facility is available, you can do salicylate concentrations to identify the trend in toxicity. However, for us, as salicylate levels are not available, in our practice, the toxicity should be guided by blood pH, because salicylate lead to severe metabolic acidosis. So metabolic acidosis represents toxicity due to salicylate. So sequential blood gases and determination of pH is helpful in determining the trend in the toxicity. And salicylate can lead to hypoglycemia as well as neuroglycopenia. In a child with salicylate poisoning, you have to treat with dextrose even if their blood sugar is normal, especially if their consciousness level is reduced, and also they might go into shock. So you have to treat with fluid resuscitation. So the two definitive methods, more definitive methods of management, are the elimination with urinary alkalization and hemodialysis. So in any child with severe poisoning, urine alkalization should be tried first. So like we discussed before, here salicylate is a weak acid. By making the urine more alkaline, we try to dissolve weak acid in that and then try to prevent reabsorption of salicylate through the tubules back to the circulation. So we try to get rid of the poison through that pathway. For that, you have to maintain urine pH between 7.5 to 8 and a urine output of 2 to 3 ml per kilo per hour. So you have to give IV sodium bicarbonate bolus followed by an infusion. And during this process, you have to monitor blood gases as well as serum electrolytes to prevent the toxicity from sodium bicarbonate. And in life-threatening overdose, or where urine alkalization is not going to be, going to cure the child, or where there is underlying renal impairment, then the option is the hemodialysis. So hemodialysis is an effective and a rapid method of enhanced elimination. It has the added advantage of correction of acid-base and fluid and electrolyte abnormalities as well. The indications for hemodialysis in salicylate toxicity are the significant CNS involvement, acute lung injury, impaired renal functions not responding to fluid therapy, significant hyperthermia. So hyperthermia can occur due to salicylate, refractory acidemia, and refractory electrolyte imbalances. Let's look at the next poison, ethylene glycol. So ethylene glycol is again commonly used poison, commonly used agents, especially used in antifreeze coolants in vehicles. Ethylene glycol or antifreeze is a colorless, odorless, sweet liquid. Because of this sweet taste, children tend to taste it and then subsequently getting poisoned. Here, the biochemical hallmark is you will find unexplained high anion gap metabolic acidosis after ingestion of ethylene glycol. How does it happen? So ethylene glycol gets metabolized inside the body and then converted to glycolic acid. So these organic acids remain unmeasurable in the blood gas. So you will find an unexplained blood gas, high anion gap blood gas. And these glycolic acids and organic acids are highly toxic to the central nervous system. It can be toxic to the optic nerve and can result in blindness, and it also can be toxic to the central nervous system, resulting in coma and seizures. And its counterpart methanol can have the similar toxic effects. And if you take sanitizers, which is used frequently nowadays, sanitizers have some amount of methanol. And if you see the cases where people died after sanitizer ingestion in the United States, they died because of the toxicity from methanol. So methanol had a similar toxic effect, leading to optic toxicity and the central nervous system toxicity. In both methanol and ethylene glycol poisonings, activated charcoal is not effective. So your treatment is you can use either fomepizole or ethanol, 40% ethanol as antidotes. And in refractory cases or severe poisoning, you have to do hemodialysis to get rid of the organic acids from the circulation. Iron. So iron is again one of the common toxins. It's used, in iron tablets are used by young children as well as pregnant mothers, as well as women of childbearing age, as a part of the contraceptive pills. So there is a chance that children ingest these tablets frequently. Toxicity is likely in doses over 20 milligrams per kilo of elemental iron, and the toxicity can be fatal when ingested a dose of more than 150 milligrams per kilo. It has 4 stages of toxicity. Initially, you can have GI symptoms, and there is a dormant phase followed by significant side effects, including significant toxicity, including GI hemorrhages, convulsions, coagulation dysfunction, circulatory collapse in cases of severe poisoning. So these children might need intubation, ventilation, and circulatory support. Here, there is no place, like we discussed before, since they are heavy metals or not amenable for absorption by activated charcoal. What you can use is gastric lavage, or in a significant overdose, you can try whole bowel irrigation to facilitate excretion of these tablets through the bowel, as effluent from the bowels. And there is an antidote for iron poisoning, which is IV desferoxamine, like we use for thalassemia. And you can IV desferoxamine can be used up to 15 milligram per kilo per hour for those present with complications like shock or coma or fits. This X-ray shows a child who has ingested radio-opaque tablets, which could be iron tablets. And then we will look at the toxicity of tricyclic antidepressants. So these antidepressants are also now increasingly used by adults for sleep difficulties as well as depression. So when they are not properly stored, children can ingest these drugs. And tricyclic antidepressants is one of the drugs with significant cardiac toxicity because it inhibits fast sodium channels in the brain, myocardium, as well as it has numerous other actions, including blockage of muscarinic and alpha adrenergic receptors. So they can have, due to the blockage of fast sodium channels, they can have cardiac conduction delays, any cardiac arrhythmia, as well as reduced cardiac contractility, as well as because of the blocking action of the alpha adrenergic receptors, they can cause hypotension. And because the anticholinergic effects, they can have dilated pupils, tachycardia, as well as convulsions. So this shows, excuse me, give me a second, I'm getting a call from the board as I'm on call. චූලනි මම ලෙක්චර් එකක් කරනවා හදිස්සි නැත්නම් තව චුට්ටකින් ගන්න පුළුවන් වෙබිනා එකක් කරනවා තව චුට්ටකින් ගන්නකෝ okay. So this shows a wide complex tachycardia induced by the toxicity of tricyclic antidepressants. What can you do in patients presenting with tricyclic antidepressant poisoning? So here the main toxicity is due to blockage of the fast sodium channels. So you have to counteract this. So here IV sodium bicarbonate used as an antidote. So it replaces tricyclic antidepressants from the sodium channels, removing the blocking effect. So main treatment in tricyclic antidepressant poisoning is IV sodium bicarbonate, and you try to aim for an arterial blood pH of 7.5. And doing hyperventilation is also helpful because that will help removing the carbon dioxide produced from the bicarbonate. And child might need volume expansion because of the blocking effect of alpha adrenergic receptors causing hypertension. So if the child is having hypotension, needs to be treated with fluid resuscitation to aim for a MAP of 70 millimeters of mercury. And if you need inotropes to treat TCA poisoning, the inotrope of choice is noradrenaline, because the main receptor it blocks is the alpha adrenergic receptors, causing predominant vasoconstriction. So vasodilatation. So in order to reverse that, you have to use noradrenaline. So it's preferable to other inotropes such as dopamine, dopamine, and adrenaline. And glucagon also can be used in severe toxicity for its inotropic effects. And so these are like straightforward presentations. If you know the drug, then you know the treatment, and then you know the end. However, children or teenagers especially might present with less straightforward presentations. For example, a child or a young person can present with a reduced conscious level, where you don't know what happened, or parents also do not know much of information. Or else a young person might present with altered behavior with no explanation. Or a young person can present after ingesting an illicit substance like MDMA. So what is your approach? What is your approach to children and young people like this? Here, so if you are not sure of the etiology or the cause of the poison, then based on the symptoms and the signs the child has on presentation, you can work out a possible toxidrome. There are several toxidromes So knowing this toxidrome will help you to come to a differential diagnosis and providing appropriate tailor-made supportive care and, if available, an administration of antidote as well. So clinical toxidromes, they stand for the clinical fingerprint characterized by a classic constellation of symptoms and signs due to toxic effects of chemicals in the body. And you see these clinical toxidromes more commonly in older children and teenagers who abuse recreational drugs. However, if you are not sure, if the presentation is less straightforward, and the child is, if you suspect a toxidrome, which I will, talk late in the next few slides, you have to think of the other differential diagnosis as well. For example, an unconscious child might present with meningoencephalitis, so it needs to be ruled out. Or they might present with hypoglycemia, acidosis, or with a metabolic crisis. Or they might present with ICH, or significant hypoxia, or hyperthermia, or even septicemia. So you need to think of these differentials in your, in the back of the mind before, narrowing down your differentials to a toxidrome. So let's look at what these toxidromes are. First toxidrome is the opioid toxidrome. The opioid toxidrome occurs after poisoning with opiate agents. So commonly used agents like, codeine. Codeine comes with Panadine, Paracetamol, and codeine, which is commonly prescribed. And morphine. Morphine is given to, people with chronic pain. So children might, child might accidentally ingest them. So their typical presentation is a triad of respiratory depression, CNS depression, and pinpoint pupils. So if you see pinpoint pupils in a child who is unconscious and who is not breathing, who is having bradyapnea, then you have to strongly suspect ingestion of an opiate. And this is especially true, heroin. Heroin is an opiate. Heroin is like a commonly abused drug by the teenagers. So intoxicated teenager might present with these three triads: respiratory depression, CNS depression, and pinpoint pupils. So why it's important to know this is, like, you can rapidly reverse this toxidrome by administering the right antidote, which is naloxone. And there is another toxidrome which goes very close to opiate toxidrome, and that is induced by intoxication with sedatives. Sedatives like ingestion of diazepam, lorazepam, these anticonvulsant medications, as well as children or young people who get intoxicated with alcohol. So they will have, in severe poisoning, they will have respiratory depression, they will have CNS depression. However, their pupils are not pinpoint, but can have a variable size, can be dilated at times, can be small at times, not pinpoint. And they can have, in addition, circulatory problems as well. They can, sedative toxidrome can lead to hypotension and bradycardia. So here, if a child presents with this sedative toxidrome after ingestion of diazepam or alcohol intoxication, then naloxone is not going to be effective, and this needs to be treated with supportive care. So you may have to give ambu ventilation for a brief period of time. You may have to monitor Glasgow coma scale over time, and if there is a concurrent low blood sugar in alcohol intoxication, you have to correct it. So likewise, you need to give supportive care. Although flumazenil is used as an antidote for diazepam poisoning, the routine use of flumazenil is not advocated because especially it can trigger seizures in children who are on long-term diazepam. And then these three toxidromes, the cholinergic toxidrome, sympathomimetic toxidrome, and anticholinergic toxidrome, they also share some of the features in common. Cholinergic toxidrome, it's a unique toxidrome that you see after poisoning with pesticides. So the more common pesticides are organophosphates and carbamate. And cholinergic toxidrome initially leads to cholinergic crisis. So that is widespread, massive activation of the parasympathetic nervous system, which leads to diaphoresis, lacrimation, urination, diarrhea, bronchuria with lots of bronchial secretions, sometimes lead to respiratory failure, vomiting, meiosis, salivation. So when you see those typical hyperactivated parasympathetic nervous system, then you have to suspect cholinergic toxidrome. So after this cholinergic crisis, patient can soon go into neuromuscular paralysis, including respiratory paralysis and death. So identifying this toxidrome helps you to administer antidotes as well as supportive care early. And then your supportive care include now decontamination. It's try not to. So this is decontamination is not helpful most of the time. So better not to attempt. This is wrong. I have put it in error. Decontamination has no place in organophosphate poisoning because it can lead to aspiration as well. However, you can use atropine to counteract the cholinergic crisis. And if the child is developing neuromuscular paralysis, you can start. You can do intubation and ventilation. And the definitive antidote is palindroxim. So palindroxim works only for organophosphate and not for carbamate. Here, the main mode of supportive care is atropine. So atropine you can initially give boluses, and then you can try atropine infusions as well. And you have to have therapeutic endpoints while giving atropine, because atropine is also toxic. So you have to monitor your heart rate, you have to monitor your blood pressure, and your axilla for dry axilla, and for your pupils. So you have to monitor these factors while administering atropine. And the sympathomimetic toxidrome and anticholinergic toxidrome, these two share common features, like they look like very similar. However, their etiology is different. Therefore, it's important to differentiate the two conditions. So both sympathomimetic toxidrome and anticholinergic toxidrome share common clinical features like dilatation of pupils, tremors and hyperreflexia, seizures, tachycardia, hypertension, hypothermia, agitation, delirium, and so on. However, there are few differentiating features. In sympathomimetic toxidrome, you see diaphoresis, whereas in anticholinergic toxidrome, you see dry skin. So that's one of the differentiating factors. So look for the skin, whether the patient is sweaty or having a dry skin. And the other thing is, listen to the bowel sounds. If the bowel sounds are exaggerated, that supports sympathomimetic toxidrome, whereas if the bowel sounds are sluggish, that supports anticholinergic toxidrome. So the etiology is different in these two conditions. If it's anticholinergic toxidrome, then your aphthana poisoning, atropine poisoning, antihistamine or tricyclic antidepressant poisoning are the etiological agents. Whereas if it's sympathomimetic toxidrome, it's mostly an illicit substance the patient has taken. And this could be cocaine, amphetamine, MDMA. But irrespective of this syndrome, in both cases, as the clinical features are similar and you have only supportive care to give, management is similar. So if the patient is agitated, having delirium, so you control delirium with sedation, benzodiazepines. And then if you have circulatory imbalance, then you correct with fluid resuscitation. And if the patient is having hyperthermia, then you have to start active cooling. Antipyretics or paracetamol has no place in controlling these types of hypothermia. And the other entity is children and deliberate self-harm. Especially older children and teenagers are vulnerable for self-harming behavior, and they can have significant underlying psychiatric problems like depression. Therefore, apart from managing the medical illness, once they have recovered, you need to refer them for psychiatric evaluation and support, irrespective of the dose they have ingested. So the key messages from this lecture: although most childhood ingestions are low lethality, poisoning in children account for significant mortality, and they can be, the presentation can be life-threatening. Therefore, it's very important to perform a correct risk assessment and then tailor-made your management depending on the severity of poisoning. And also in older children, it's very important to identify toxidrome that will help formulating the right differential diagnosis where the presentation is less straightforward.